Good evening, everyone. Thank you for the opportunity to speak with today and share our paper, A Layered Approach to Neck Lift, with you all. Would like to thank the Journal of Plastic and Aesthetic Research. It's been a pleasure working with you all, and it's an honor to be here. I look forward to the discussion along with Dr. Nahai. I'd just like to begin by playing our video abstract that we have submitted on the journal website. No sound. No sound. Need to put the volume up. Dr. Nahai's layered approach, which he first published in 2005, provides a helpful guide for diagnosing the anatomical problem and selecting the best treatment for each patient. We hope you enjoy reading.
Long before I wrote about the layered approach in the first edition of The Art of Aesthetic Surgery, I had been practicing it. Given my interest in anatomy and interest in neck and facelift, I realized that there are 3 layers to the neck: the skin and subcutaneous tissues, the platysma, and the structures deep to the platysma, including the digastric, subplatysmal fat, submandibular gland. And I also would like to emphasize that if I plan to operate deep to the platysma, I do that first and see if that has recontoured the neck sufficiently before working on the other 2 layers. I will join Andrew in inviting you to read our article, and I trust you'll enjoy it and find it informational.
So while beauty can sometimes thought to be in the eye of the beholder, we all know that there are a number of objective parameters that are consistent with aesthetic ideals. This paper, published in Plastic and Reconstructive Surgery in 1980 by Ellen Bogan and Carlin, is considered one of the first to characterize and define aesthetic ideals of the neck. The authors discuss 5 different criteria. The first is a distinct inferior mandibular border. The second is a subhyoid depression. Next is a visible thyroid cartilage bulge. And afterwards is visibility of the anterior border of the sternocleidomastoid muscle. And then most importantly, submental sternocleidomastoid angle of about 90 degrees. And deformities of the neck can be thought in 2 general categories. The first one being acquired, which is, of course, the most common due to the aging process. In terms of the acquired etiologies, we generally appreciate 3 different presentations. The first is the development of skin redundancy, which can be either apparent or real. Apparent being defined as visually appearing to be excess skin, but upon recontouring the deeper layers does not end up with excess, versus real, in which does lead to excess of skin that cannot be smoothly redraped on the deeper structures of the neck after recontouring. Platysmal bands, which can of course be static, i.e. present at rest, or dynamic, present on animation. And of course, these bands can be either medial, lateral, or both. And then lastly is submental fullness, which can be broken down into fat excess, digastric muscle hypertrophy, and submandibular gland prominence. Submandibular gland prominence being either from hypertrophy or ptosis. But we must not forget that cosmetic neck deformities can also be congenital as well, due to the patient's native anatomy. Fat excess certainly can contribute to it, either in the subplatysmal or subcutaneous planes, but usually these are due to microgenia, retrogenia, or a caudally positioned hyoid bone. The paper sought to review Dr. Nahai's layered approach to neck lift. The 3 layers include the superficial, intermediate, and deep, wherein the superficial layer includes the skin and subcutaneous fat, intermediate layer, the platysma muscle and interplatysmal fat, and deep layer, which can be broken down into soft tissue and skeletal structures. Soft tissue being the subplatysmal fat, digastric muscles, and submandibular glands, and skeletal structures being the mandible, hyoid bone, and cervical vertebra. This table 2 of our paper, reviews the surgical treatment options. And we use the term guide here as opposed to, for example, algorithm, because the approach to a neck lift must be tailored to the patient's particular anatomy, cosmetic deformities, and their, of course, cosmetic goals. So just to review, the parameters that we evaluate on every patient in thinking about the treatment that might be best for them include the skin excess, skin elasticity, and fat excess. In order for a patient to be a candidate for isolated liposuction, we would look for a patient who's generally young with good skin elasticity, no skin excess, and has the majority of their fat excess in the subcutaneous plane. Once a patient develops apparent skin excess or develops fat excess in the interplatysmal or subplatysmal planes, then liposuction is not a good treatment, and a submental neck lift is indicated. When the skin excess becomes real, then it's required to have the ability to recontour the deeper structures of the neck and add a retroauricular incision potentially as well to excise skin. Lastly, once a patient develops jowls, that's thought to be secondary to midfacial descent, and the patient may not be an ideal candidate for a neck lift procedure alone, and it should be discussed and encouraged that the patient undergoes a simultaneous facelift with the neck lift. Now I'll turn it over to Dr. Nahai.
Before we get to the case examples, I wanted to greet everyone. Special hello to my friends, Daryl in Sydney, Oscar in Florida, Diane in Colorado, and Andre in Curitiba, Brazil. I'd like to thank Andrew, who is our aesthetic fellow, nearing the end of his 1 year of fellowship with us, who has seen me do all of these procedures in the operating room. I've had an interest in this since I started practice 42 years ago. Back then, there was very little interest in the neck. Everyone concentrated on the face. And I remember some very senior people at the aesthetic meeting saying, well, my patients aren't worried about the neck as long as the face looks good. We've already seen that article by Dr. Ellen Bogan, which is a classic. Everybody tries to strive for that. We try to strive more for what's best for that patient with a custom-made or bespoke approach. I don't do the same operation on everyone. And early in my career, I saw some of my own disappointing neck results. I had some referred to me, and that's how I learned about the neck. That's how I decided that I look at 3 layers in the neck that Andrew has already presented. Then in the early 80s, along came liposuction. And everyone said, this is the answer to the neck. We don't need to open. We don't need do anything, just do the lipo. As you'll see when we show our case examples, it worked for some, but not for all. Even today, I see poor results because someone has tried liposuction in the superficial plane instead of dealing with the issues in the deeper plane. So when I examine a patient, schedule them for face and neck lift, I try to assess whether the volume is superficial or deep to the platysma, by getting them to grimace like this, contract the platysma. I put my hand under there, and if nothing changes, then it's all superficial. But if I don't have anything in there, then it's all deep. And surgically, the operative plan, if I know I'm going to operate deep to the platysma, I'll allow a few extra minutes. And I always like to start working deep and then superficial. If we're going to work on subplatysmal fat, digastric, submandibular gland, I do that first. And then I bend the neck. I look at the volume. I pinch the subcutaneous fat. If that is sufficient and that neck has been recontoured, I do not touch the subcutaneous fat, and we'll see a case example of that. I would be remiss if I don't talk about safety. I think through the work of some of the people that I've already acknowledged today on this get together, through their efforts, there's a renaissance and great interest now to working in the subplatysmal space. During my career, I know that others have criticized those of us who worked under the platysma over these 40 years, saying it's unsafe. You're going to have hematoma that obstructs the airway. I'm pleased to say that I've not had any of those in over 40 years. In 2004, we presented our experience at the Aesthetic Society with subplatysmal work, without a hematoma, without a siloma, without any dry mouth, or without any nerve damage. More recently, Andre Auswald has published in Aesthetic Surgery Journal with well over 450 subplatysmal procedures without any morbidity hematoma. So the debate right now is for those of us who do these procedures to convince our colleagues that this is safe and very effective. So with that overview of where I started and where I am now, and how our approach to the neck has changed from do nothing, liposuction can do it all, to now many of my friends and colleagues doing excellent work deep to the platysma. So let's go ahead and look at some case examples.
Thank you, Dr. Nahai. So this first case is figure 3 in the paper. Shows a relatively young patient who has, we would consider, very little, if any, skin excess. And as a result of her good skin elasticity and fat being in the subcutaneous plane, she was thought to be an excellent candidate for isolated liposuction. And you can see here the preoperative and postoperative results. In figure 4, you see a gentleman who on exam has submental fullness in the deep layers, intraplatysmal deep and deeper subplatysmal fat. And so given that this patient had, what we would consider either no or an apparent skin excess, again, good skin elasticity, but the problem was the location of the fat excess. He was a good candidate for a submental neck lift with an anterior only approach. Lastly, this is an older woman who has signs of cosmetic neck deformities, but in addition, also has the development of jowls. And so, in terms of discussing treatment options with the patient, a neck lift alone, while it might improve the jowl area somewhat, you can see she also has prominent marionette lines, nasolabial folds, as well as midfacial atrophy and ptosis. She was a best candidate for a combined face and neck lift. But as I mentioned, the presence of mandibular border effacement as well as the jowling would make an isolated neck procedure in our judgment less ideal.
I would like to add that I would like to add that on this patient, as I described earlier, we went deep to the platysma, worked on the digastric, worked on the submandibular gland, and did nothing superficial to the platysma. I have seen too many people with oversuction in the neck where the platysma adheres to the skin, and on animation, we can see that irregularity. And Andrew, if you can go back to that gentleman, in addition to working deep to his platysma on the deep structures to recontour his neck, this is what, about 30 years ago, I put in a chin implant in him as well. Today, I would probably fat graft, but I would do exactly the same approach, submental approach, work deep to the platysma. He has youthful elastic skin, so no need to remove any skin. So we'll turn it over to the moderators. We're both happy to answer any questions. Maybe they didn't hear me. Do you want to tell them?
Oh, and so, sorry, would you mind just turning it down a little bit, the volume? Dr. Nahai, would you mind just turning the volume? So last, we would just like to review the indications for opening the neck that we include in table 3 of our paper. The first deals with the skin quality and quantity. So for patients with excess inelastic central neck skin or deeply etched transverse lines, opening the neck really facilitates skin undermining and redraping. For patients with excess inter or subplatysmal fat, again, opening the neck is necessary, submental neck lift approach for resection of that. For access to the deeper compartments. For patients with visible medial platysmal bands that are closer together, an anterior approach allows for medial plication, potentially myotomy or myectomy, depending on whether the bands are static, dynamic, or in secondary cases, recurrent or recalcitrant. Finally, the digastric muscles and submandibular glands are best addressed through the anterior approach as well. In summary, neck aesthetics are a vital component of cervical facial beauty. There are many techniques, from non-surgical to surgical, for improving cosmetic neck deformities, ranging from superficially the skin down to the deeper neck structures in the deep layer. The key is to accurately diagnose the anatomical problems and apply the best treatment to achieve the desired result, which, as Dr. Nahai said, is really different for everyone. And this is something that should be thought of in terms of your cervicofacial analysis as not only addressing the neck, but also the face in patients who are presenting as a result of the aging process. Thank you for your attention, and we'd be happy to discuss our paper in greater detail at this time.